So I'm going to shift a little bit and turn to polychlorinated biphenyls and going to talk about their role in steatohepatitis. So for disclosures, this work is funded by NIEHS as well as through a contract with ATSDR. So the relationships aren't really relevant to this. So overview of polychlorinated biphenyls, or PCBs. So there were approximately 1.3 million tons of PCBs manufactured in the U.S. Prior to 1977. And these were made by Monsanto under the trade name Aromatic. There's a picture here of what a PCB looks like. There's 209 congeners, and the variation comes in the chlorine substitution patterns. So there's apparently 209 different ways you can arrange chlorines on this molecule. So these are persistent organic pollutants, and that's by their nature. So they have extremely high thermodynamic stability, and in fact, that they were used in electrical transformers, capacitors, that type of thing. And so the concept is you can pass a million volts of electricity through these things, and they don't degrade. So they're very thermodynamically stable. And so if a million volts of electricity isn't going to degrade them, a P450 isn't going to degrade a lot of them either. And so a lot of them are POPs. Now the lower molecular weight PCBs can be metabolized and are metabolized. And Larry Robertson has spent a lot of time recently studying them. I'm going to talk more about the high molecular weight PCBs, which are metabolized. Don't get me wrong, they're just metabolized so slowly. For example, PCB 153, which is the most abundant PCB in men, is metabolized over about 5 rodent lifespans is the half-life. So extremely slowly metabolized. Let's see, Arnie. There's Arnie. So referenced Arnie. He's done a great study on how PCBs contaminate the food supply, where he purchased food from a Dallas supermarket, measured PCB load among other POPs in the food supply, and we eat PCBs every day, a certain amount that Dr. Schechter was able to measure and report on. Even if you don't care about PCBs, GE does, because they're paying about $1 billion to clean up the Hudson River. So this is the largest, most expensive Superfund cleanup in history is related to PCB contamination in the Hudson. All right, so NASH we talked about yesterday and a little bit today, generally thought to be due to caloric excess, although environmental chemicals can play a role, which I call TASH. Steatohepatitis is very common, about a third of adults, and alarmingly growing even more rapidly in adolescents and children. Now, NASH increases liver-related mortality, but most importantly, and I'm going to come back to this at the end of the talk, NASH really drives cardiovascular risk, and there are many people that believe that this is the most important independent risk factor for cardiovascular disease. I'm not sure if that's true or not, but I've heard some cardiologists that believe that. So several stages of steatohepatitis, if you will, illustrated on the bottom. So the majority of this talk, I'm going to kind of shift gears from the earlier lectures today, because I'm going to talk mostly about epidemiology. And as I look over the field of environmental liver disease, from big picture standpoint, one thing we really need is more epidemiological studies to more clearly define the potential role for chemicals in liver disease. And so I'm going to talk about first study that we did to do this, and we used some NHANES data, and I was really pleased to see a couple of NHANES reports. Dr. Chatterjee mentioned one that he's going to be publishing soon. So it's really kind of neat looking back, because our group, I believe, was the first group to ever use NHANES to look for environmental liver disease. And I'll talk a little bit about that. So people now call this an unbiased exposome-wide steatohepatitis study. So when we first did this, we didn't know this language. So I think we just called it TASH. So what the NHANES did is that they've got at least in NHANES 2003-2004 at the time we did this, they had 196 measured pollutants from 17 subclasses. And so what we wanted to do was take all 196 of these pollutants, rank people from either first exposure quartile to fourth, and then maybe have another quartile for unexposed. And our primary outcome variable was dose-dependent multivariate adjusted odds ratios for unexplained ALT elevation as defined by greater than 48 for men or greater than 31 for women across the exposure quartiles. So that what that means, we wanted to find people that were unexposed, calculate their or set their risk for liver disease as 1, if you will, or 0, and then look going across in a dose response fashion to see if, if you start here and then you go up in a stepwise fashion across the exposure quartile. So a limitation to this design is that we couldn't take into account non-monotonic dose curves, which I think are probably going to be important with POPs. But nonetheless, that's what we did. We made adjustments for age, sex, race, poverty income ratio, HOMA, body mass index, and then for multiple comparisons. And so this is an example of what we started off with. There were 10,000 subjects in NHANES. We only wanted to look at adults, and we wanted to look at unexplained ALT elevation. Now that had been used for several years to calculate the prevalence of NAFLD. And so what you do basically is NHANES measures hepatitis B, hepatitis C, hemochromatosis biomarkers, so alcohol consumption. So if you throw out all of those, you're left with a population that has ALT for no other reason that you could think of except for NAFLD. Now there's probably some PSC, some primary biliary cirrhosis, some of those lumped in, but for large studies this has become an acceptable method prior to us doing this study design of measuring suspected NASH. So we excluded these people, and we ended up with this subpopulation of about 4,582. We wanted to adjust for insulin resistance because there had been some prior reports of environmental chemicals causing insulin resistance, and insulin resistance can in turn cause liver disease, and liver disease can in turn cause insulin resistance. So it's a very complicated scenario, but we wanted to make some adjustment for insulin resistance. So not everybody had insulin resistance or HOMA score measured, and so that took us down to this number here, 2,000. And then of the 196 pollutants that were measured, they were measured kind of in thirds of this population here. And so we ended up with numbers of around 700 or 800 in each of these groups. And so these are some examples of what were measured: PFCs, VOCs, heavy metals, arsenic, mercury, organochlorine pesticides, PBDEs, PAHs, phthalates, dioxins, PCBs, VOCs, organophosphorus, insecticides, etc. And so this is how our demographics worked out, and in terms of population distribution. And here you can see the prevalence of increased ALT. So it was higher in women in this study than men, and the number was about 10% roughly was the prevalence of suspected non-alcoholic fatty liver disease. Now this is something that Dr. Voss talked about, and this is something again that's seen in all the NAFLD epidemiology studies, is that Hispanics are more sensitive, so 18.6% prevalence in Hispanics, and then whites kind of being in the middle with 10% prevalence, and then non-Hispanic blacks 5.6%. So it seems that Hispanics are very susceptible to this. Whites are in the middle. African Americans are protected. Dr. Voss reported on that yesterday in children. It holds true in adults. It appears to be a disease of middle age, and it's associated with increasing BMI, as one would expect. So you eat more calories, higher fat diet, whatnot, you're more likely to get NAFLD. So that's known too. And so what did we find? So we found that by classes, PCBs, lead, and mercury were dose-dependently associated with ALT elevation and suspected NAFLD. And among PCBs, 9 of 10 coplanar PCBs were associated with ALT elevation, and 11 of 25 non-coplanar PCBs were associated as well. So both AHR agonists and other PCBs that are not AHR agonists were associated with NAFLD. Now, who had the highest PCB burdens by demographic factors? Well, those with older age, presumably because they've had more time to acquire POPs through their diet over their lifetime, and then for reasons that aren't entirely clear to me, non-Hispanic blacks had higher PCB levels. Now, what about the odds ratio? So these are the kind of simplified presentation of the data. We kind of lumped the non-coplanars and the coplanars together in classes, and you can see that we don't have a unexposed level as a reference range because every single subject in NHANES had detectable PCB levels, which I think is remarkable because these don't exist in nature. So these are entirely man-made chemicals, and they've been banned since 1977. And so every single NHANES subject had them in their body. So we set the first quartile as the reference, and you can see if you go up to the fourth quartile for a coplanar, the odds ratios for having suspected NASH was 7.6 for coplanar PCBs. Non-coplanar PCBs was 4.5, and then total lumping these together was 4.3, and these were all statistically significant. So conclusions from NHANES that the adult NAFLD prevalence was about 10.6%, and this was much lower than the MR spectroscopy data of 33%. And so one conclusion is that ALT, at least at this cutoff, is not a very sensitive biomarker for suspected NAFLD. And second conclusion, again, is the role of ethnicity in development of NASH. PCBs have a 100% exposure rate in U.S. population. Older subjects and non-Hispanic blacks had higher PCB levels, and there were dose-dependently increased odds ratios for PCBs, as well as lead and mercury, which we really haven't looked at, lead and mercury component of this. Although there was a subsequent paper follow-up to this by another group that looked at synergy between mercury and PCB exposure at NHANES because you get them both from eating the same fish, basically. And so there is a synergistic effect of, appears to be, of mercury and PCB exposures. And the final conclusion is it doesn't seem to matter what type of PCB it is, whether it's a coplanar or non-coplanar PCB, they both appear to cause NAFLD. So kind of in follow-up of this, we asked another question, and so that question was, well, it looked like ALT was not performing well as a biomarker, and so what if we did a similar population-based study with a better biomarker, what would we find? And so we used a biomarker that we've done in some of our prior vinyl work called cytokeratin 18. Now, cytokeratin 18 is a cytoskeletal intermediate filament protein, and it's a biomarker for hepatocyte death. And so it was traditionally thought to be kind of a spillage protein, and so if you have cell death, the cytokeratin 18 kind of comes out and can be measured as an intact protein, which they call M65. But the neat thing about this, and the biomarker is somewhat mechanistic, because during apoptosis, the cytokeratin is caspase cleaved, and you can measure caspase cleaved fragment, which they call M30 antigen. And so you can, by measuring these things, get a flavor of whether you're having apoptotic cell death or non-apoptotic cell death, presumably necrosis. So Dr. Zacharewski mentioned necrosis, and I think this is a recurring theme as well. Chemical hepatotoxicity has a lot of necrosis rather than other forms of liver disease, which are primarily apoptotic. And so M30, the reason we use this is M30 has been validated for clinical research in NASH. Now, there's some new data on M30 where it appears that it doesn't just float around as a spillage protein. It's actually bound to the surface and resides within liver microparticles. And so this is also, when you're measuring cytokeratin 18 M30, you're actually measuring microparticles, and DAMPs can reside in these microparticles as well. So the biology of this biomarker is actually somewhat complicated, but it worked well, served us well in previous studies. Now, this was a slide we presented at SOT, or a poster, a couple years back, where we took people that were healthy, had NASH, obese people with NASH, alcoholic cirrhosis subjects, and these were some of our vinyl chloride workers. And you can see that if you take a ratio of necrosis to apoptosis, you can see that the vinyl workers had more of a necrotic type cell death, and whereas alcohol was in the middle and NASH was primarily apoptotic. So if you do a liver biopsy on these patients, they all look the same, but the mechanisms of cell death are different. And so by using this biomarker, we can begin to tease out the mechanism of cell death and decide, well, who has TASH, who has alcohol, who has NASH. And so we've done this in a couple of previous studies and found out that it seems to hold for vinyl exposures, acrylonitrile, butadiene, and styrene exposures, as well as environmental organochlorine pesticide exposures. So we wanted to use that in a population, human population, and so we linked up with Marian Pavic at the ATSDR and obtained access to samples from the Anniston Community Health Survey. So this slide kind of talks about Anniston and that survey. So this is a heat map of PCBs, and we're close to one. So there was a electrical plant of some kind in Bloomington, Indiana that used a lot of PCBs. I can't remember whose plant that was. You remember, Cam? GE in Bloomington. But the big problem's down here in southeast United States, and that's because of Anniston, Alabama. That's where the PCBs were made. So this is a small town, about 24,000 people. It was made famous in the 1960s because of the Freedom Riders and the buses. There was a bus that was burned there, and they manufactured PCBs from 1929 to 1971. And so the Anniston Health Survey went to measure exposure to PCBs and health outcomes in people living near the Monsanto plant. And so in comparison to NHANES, which I just reported, Anniston residents have higher PCB levels. Again, African Americans were higher than the whites, and PCB levels were higher with age, probably due to increased time for bioaccumulation again. And so researchers in this group have previously reported on associations between PCB congeners and hypertension, which I guess is the same thing as blood pressure, serum lipids, and diabetes. And so there's a lot of work presented recently at the dioxin meeting, Dr. Pavic presenting some results that we've done in collaboration with him on diabetes. And so here's a map of Anniston, and so it's actually much worse than just Monsanto. So red is where Monsanto is. There's also like a chemical weapons dump or something over here in a depot. And a lot of these chemicals kind of come in these creeks here, and you can see do not eat fish from this water, and that's because they're highly contaminated with PCBs. Now, an unusual thing that some of the residents do, I guess it's unusual to me, but not unusual for Southeast, is they have a form of pica, and they eat soil. It's called kaolin. And so it's not good to eat dirt when you live out back behind a Monsanto plant, but that's what some of these residents have done, and that's one of the reasons they have high levels. So Anniston Community Health Survey obtained informed consent, interviewed over 1,000 adults. There were 774 participants that provided blood samples. We had access to about 741 of those. PCBs were measured. Now, these were the non-dioxin-like PCBs that were measured in this survey because they're present at much higher levels in humans, and you don't need to have as sensitive methods to measure them. And so that was a limitation of this study. And in fact, there was an ACHS2 study, which is ongoing, where they obtained more blood from these residents to go back and measure the dioxin-like PCBs, as well as other dioxins, I believe. So we measured liver disease biomarker panel on them, and we classified people as having no liver disease if they had normal cytokeratin 18s, and the true normal or reference range isn't known, but from the literature and from some of our prior studies, we've used these cutoffs. Now, if they have TASH, they have more of a necrotic liver death. And so we use an M65 elevation with a normal M30, and then we had another category of no liver disease. And we adjusted for total lipids, age, race, gender, BMI, diabetes status, and alcohol use. and used linear regression models. So here's the results. Let me go back first with a little demographics before we do results. So age, 54 years old, average BMI was in the obese range, 31, which is not surprising, I guess, for southeastern United States. As in many of these surveys, you'll have greater female participation than male, and that may be reflective of more men working and more women at home in that population, and about equal numbers of non-Hispanic whites and African American blacks in the population. Now, if we look at the liver disease status, what we found, and this was alarming to me, was that instead of 10% prevalence of liver disease, it's now 60% in this obese population of highly PCB-exposed people. And if you look at the pattern of the liver disease, most of them had the M65 elevation consistent with TASH from our prior study. So nearly half of them had that. 11% were in the other liver disease range. And were there any demographic factors associated with these groupings? Well, there was no significant effect on BMI, and there was no effect on PCB load in these subjects determining what group they are. But I will say there was a trend toward lower BMI in the TASH group and higher PCB level trend. And I mention that, even though it's not significant, because Banrita Walling, my graduate student, has found with Aerocor 1260 exposures, which mimic bioaccumulation patterns in aniston, the mice with fatty liver actually are thinner. So that may be a real finding, even though it wasn't significant, but more data are obviously needed. Now in NHANES, more women than men had fatty liver, but this was flipped in ACHS, where that men had more fatty liver than women, and there was a difference in ethnicity again. And so it still holds true that whites had more fatty liver than the African Americans, but instead of a few percentage points, it was 22% different in terms of prevalence. And so this was very alarming to me in that we had such a high prevalence of fatty liver disease, and it appeared to be the pattern consistent with what we call TASH. Now, were any of these other biomarkers measured? Did they give us any clues or any additional information? So, sorry, phone ringing. So what we found was that in the group with suspected TASH, they had higher fasting insulin levels, suggesting insulin resistance. And that's known to be, we've seen that previously in TASH, and that's also known in NAFLD as well. And then we've heard some mention about coagulation system, and we found that in the TASH group had higher PI1 levels compared to those without liver disease. And we've heard about inflammation during this meeting, and those with TASH had higher MCP1 levels than those without liver disease. Now, this was kind of a surprising finding, but we've seen this in multiple animal studies. So it was reported in this population that they have an increased prevalence of diabetes. But what we saw was that with increasing PCB level, regardless of what group you're in, insulin actually goes down. And so it seems that PCBs may not be causing insulin resistance as much as they're causing hypoinsulinemia. So it may be more of like a type 1 diabetes or a type 1.5 diabetes, if you will. And we saw, because they do have insulin resistance, at least the ones with liver disease, the TASH is probably causing some insulin resistance, but over time the insulin, or with increasing exposures, the insulin's going down. So the diabetes story is incredibly complicated, and leptin had the same pattern with increasing PCBs, leptin's going down. So we think PCBs may be doing something in the adipose, which is where leptin is made. Now, I think the PI1 is an important story here, and it's getting worse. So these are some preliminary data from the aniston 2 recontact study, which is, we just got these about last week or so. And so the M65, the mean between the ACHS1 and the ACH2 samples, which were collected late last year, earlier this year, that stays the same. So it looks like liver disease isn't changing much, but the PI1 levels are getting worse. And I'm going to switch gears a little bit and focusing on Pi1 again and show some animal data that show a story between PCBs and Pi1, even in animals. And so these are some experiments that Van Rita did. She did a 42% milk fat diet versus a control diet, 12-week study, and gave, in a 2x2 design, treated mice with either PCB 153, the most common PCB in man, at a total dose of 200 mg per kg, and that dose was selected because it was the high dose in the NTP long-term carcinogenesis study. And I believe, Jim, you may have done some adduct work in animals from that study, and so we used that. That's a higher dose than people are exposed to, but we chose it due to NTP literature. And then we did Arocore 1260 at a low dose, which is reflective of what people in Anniston were actually exposed to, 20 mg per kg, and then we did a 200 mg per kg cumulative dose as well. And so what we found with the PCB 153 experiment was that on a control diet, PCB 153 didn't do anything. And we actually even did a liver metabolomics analysis, and not one single metabolite was changed by PCB 153 on a control diet, which was really remarkable to me anyway. High-fat diet on oil red O, we see some lipid droplets forming, but the combination of the high-fat diet plus the PCB 153 caused steatosis, but there was not much inflammation or fibrosis. So these were really fat mice with really fatty livers, and they had high ALT levels, and look at the Pi1. So this is similar to the Anniston human study in that if you have diet-induced steatosis and you throw PCBs on top of it, the Pi1 goes up. So there's an interaction there. And we saw something similar with the Arocore 1260, which mimics accumulation patterns in Anniston, whereas even the low dose, actually, and this is why I suggest that there may be a non-monotonic dose curve, because we saw differences between the low dose and the high dose, and that the low dose might have even been worse. But we see worsened steatohepatitis with Arocore 1260, and it was different. So the steatosis wasn't worse. So PCB 153 made steatosis worse, but inflammation was not worse on pathology in the liver. But the Arocore 1260, the animals, if anything, were actually skinnier, but they were more inflamed in the liver. And here's an example of some liver inflammation. But a similar story again, in that if you had diet-induced steatosis, throw Arocore 1260 on top of it, even at the low dose, which is reflective of Anniston, hopefully, you get Pi1 increase. And so in conclusions, PCB exposures appear to be associated with steatohepatitis in now 2 population studies, and I've showed data for a couple of animal models as well. And there does seem to be an interaction between both ethnicity and gender on this, and that what we saw in NHANES was magnified in ACHS cohort, at least the impact of ethnicity. So whites seem to be more sensitive to fatty liver than blacks, and that sensitivity is further magnified when we have high-level PCB exposure. So there was a 22% delta between whites and blacks in Anniston in terms of prevalence of suspected TASH. And then the gender was flipped. So in NHANES, there were more females than men with suspected fatty liver, but in Anniston with higher PCB levels, that flips until now that the men were more commonly involved. So PCB exposures or in ACHS previously were associated with diabetes, and we expected to see insulin levels rising with increasing PCB exposures, but the opposite was true, that insulin levels dropped. But for me, the most important thing is that diet-induced steatosis and PCBs appear to interact and increase prothrombotic Pi1. And this is important because NASH, fatty liver, is known to be a major driver. Again, some people believe the most important driver of heart attack and stroke. And so what I'm suggesting, I haven't proven this, but what I'm suggesting that if you take someone that has diet-induced obesity, give them PCB exposures, the PCB exposures may drive the prothrombotic PI1, and that could be the mechanism of heart attack and stroke or increased cardiovascular risk in NASH. So that risk could be driven by environmental exposures is what I'm proposing. Again, haven't proven, but just a proposal. And so I think that's something that's going to be important to look at as a group when we study environmental liver disease, is to be careful not to be too liver focused. What are the impact of environmental liver disease on the rest of the body? And so I'd like to acknowledge collaborators. Jose, I guess you got us in basketball in 2014, but 2013 U of L was there. And maybe we'll be back this year, I don't know, we'll see. And then also like to acknowledge the participants in both NHANES and the Anniston Community Health Survey. So thank you. Any questions? Arnie?
Matt, that was a very elegant description of a bunch of sophisticated studies. I'm trying to focus on what's causing what or what's associated with what. With the non-dioxin-like PCBs, we have one set of chemicals. With the dioxin-like PCBs, we have chemicals which act like dioxins. We know that usually we've also got the benzofurans as well as the dioxins. And these are usually described on a lipid normalized basis, which I know that you do not do in the wet plate.
Oh, yeah, I didn't give all the details, but they were lipid adjusted.
Sure, okay. But could you just clarify for us what you believe the role of the non-dioxin-like PCBs, the dioxin-like PCBs, the benzofurans and dioxins were in these studies?
So not all of those factors were measured in Anniston 1, and so that's why there's Anniston 2. So I can't tell you that now. Hopefully in a year or so I'll be able to tell you that. And in NHANES, they did measure dibenzofurans and dioxins that weren't PCBs, and we saw no relationship with ALT, although I'm not sure I necessarily believe it due to limitations of the biomarker ALT in that setting. So if any... Let me take, I don't know, one or two more questions, and we got to get back on schedule. Jim and Dave.
So the discussion this morning is pretty much focused on the hepatocyte effects. But if you look at PCB 153 and its synergy with the dioxin-like PCBs, there's a marked increase, a synergistic increase in oxidative stress and in cholangiocarcinoma. And yet, did you have any biomarkers of cholangial disease?
So I looked in NHANES at alkaline phosphatase and really didn't see a whole lot. Probably should look at GGT, and we've done that before, haven't published that yet. And actually, when you do a similar NHANES analysis with GGT, things like arsenic start popping up. And so it kind of changes what you get. But no, we didn't look at that. I mentioned we did do a metabolomic study on liver from PCB 153 mice, and we saw a profound downregulation of glutathione in the co-exposed animals. So I think that indicates that we may be seeing in our hands the oxidative stress that you've noticed too, at least with low glutathione levels as a readout.
But we don't find it in PCB 153 only.
Okay, yeah, we didn't either. We saw it with 153 with high fat, we see it. And so you didn't see it with 153 alone either? Okay, so I guess you could either have dioxin-like PCBs plus non-dioxin-like PCBs maybe has a similar effect as a non-dioxin-like PCB plus high-fat diet, at least in terms of oxidative stress. Okay. Yeah.
One of your sub-cohorts of NHANES looked at PFCs.
Right.
The only thing that we've ever really seen in occupational exposures of PFCs was increases in ALT. So did you see anything in the essentially lower dose?
For PFCs, we didn't see anything, but again, that's one that I don't believe the results. Well, I believe the results, but I don't trust them because of limitations of ALT as a biomarker. So others have seen slight increases. So I've been talking with the group in West Virginia recently that has like a 63,000 sample cohort of DuPont when they dump PFOS and PFOA, and so they've seen like ALT going from like 20 to 22 or something. It was a small increase, but it was statistically significant. And so we're actually in negotiations with them to get some of those samples here and use our more sensitive biomarkers, because I think we're going to find something. I know Dr. Slit's got animal studies showing fatty liver with PFCs, and so I'm guessing that this is a failure of biomarker type situation for ALT, and so that's one thing I'd like to call attention to is biomarker development for environmental liver disease, because I think we're missing a lot. Okay, thank you. Wynn, you ready?